everyone, and welcome to MedSynapse podcast series, where we bring you expert insights on groundbreaking medical advancements. I'm your host, Hetvi Shah, and today we're exploring one of the most revolutionary breakthroughs in cancer therapy, CAR T cell therapy. This cutting edge immunotherapy is changing the landscape of hematologic cancer treatment, offering new hope to patients with limited options. And to help us understand its full potential, we have with us Dr. Kunal Goyal, a renowned hematologist, bone marrow transplant specialist, and CAR T therapy expert. He's the head of Haemato-Oncology and BMT at ICTC Mumbai and a consultant at Kokilaben Dhirubhai Ambani Hospital in Navi Mumbai. With his vast experience in treating blood cancers and pioneering advanced cellular therapies, Dr. Goyal is at the forefront of bringing CAR T therapy into mainstream clinical practice, which makes him the perfect expert to guide us through this discussion today. So, Dr. Goyal, it is truly an honor to have you with us today and welcome to the show.
Thank you, Hetvi. Thank you for the invitation, and thank you, MedSynapse community, for inviting me.
Yeah. So, Doctor, let's just start with the basics. So, could you briefly introduce CAR T cell therapy and its significance in hematologic malignancies, and why is this considered a breakthrough treatment?
Yes, so now there is a shifting paradigm in the treatment. Previously, there were chemotherapy. Now they have changed to chemoimmunotherapy, and now completely to immunotherapy and cellular therapies like CAR T cell therapy. What is the significance? Let me tell you. So there is a guy who is a DLBCL double hit lymphoma patient. He has received a standard therapy like R-CHOP. After R-CHOP, he relapsed early, within 2 months of the completion of therapy. And then this becomes a very aggressive disease because of the disease biology also, and the disease relapse within 2 months. Now, he typically receives the salvage regimen, and if he achieves complete remission, then he undergoes autologous transplant. But there is a lot of patients like this in whom chemotherapy doesn't work. So this patient again was treated like bridging therapy or salvage therapy with standard therapy. And after this therapy, the chemotherapy didn't work. So these are the chemo refractory patients. They, in them, transplant doesn't work. Autologous transplant, further chemotherapy won't work. Or if at all it achieves a CR, it will be a small duration response followed by a relapse. And in majority of the person in Indian scenario, there is a lot of cost issues also. There is a lot of toxicities with these chemotherapy, and if it is not working, then there is no use of these things. So what CAR T has done is there the patients in whom relapse after autologous transplantation, those who are progressive disease and chemotherapy is completely refractory, we now have an option of CAR T cell therapy or cellular therapy. Previously, these patients unfortunately were treated as a palliative care, so they have a survival of hardly 1 to 3 months. Now, with the CAR T cell therapy, they have a fair chance they can have a good response and they can have a durable response, at least in the 40 to 50% of the patients. So, I can explain you with the previous example. The guy had a disease relapse within 2 months of the treatment. He received high dose methotrexate based matrix regimen, and on the treatment, he achieved partial response. But while he was on treatment, in 5 to 10 days, his tumor again started to increase, and it increased to 200 times in 10 days of span, indicating there is a tumor which is highly chemorefractory. In that patient, we have used bridging therapy with the radiation and all these things and CAR T cell therapy. Now the patient is almost 3 months above. He is complete remission and he's doing well. Otherwise, the prognosis of this patient was he could have succumbed at least 6 or 7 months earlier. This patient belonged to US. He left his job. Now the same company offered the job to him, and
Wow.
he's completely enjoying his life. So this is the impact of CAR T cell therapy. So you can turn lots of palliative patients into curative one. This is the potential in refractory lymphomas, in refractory ALL. I am not saying it will be 100% cure in every patient because the disease biology and disease burden and lots of issues, frailty and multiple things are there, which are the determinants of the response. But if CAR T is used appropriately in timely manner and in a smart way, then you can save a lot of people and you can give them a new life. So this is the significance before CAR T. So CAR T is chimeric antigen receptor T cell therapy. You know, chimera comes from the word Greek mythology, and there was a fire animal which has a head of lion, and there on their body there was a body of a goat with the head of a goat and serpent tail. So it was a deadly creature which has a mixture of multiple animals. So chimera comes from that term. And in CAR T cell therapy, there are T cells. In general, the T cells helps in protection from viruses, certain bacterial infections, and our day-to-day body produce lots of cancerous cells which are detected by these T cells with the help of other cells like antigen presenting cells and other immunity cells. And with the help of cytotoxic T cells, that is CD8 positive cells, we can kill them and we don't have cancer. So these are the normal mechanism. What happen in cancer due to certain mechanism, due to certain receptors, due to certain antigens secreted by the cancer and the microenvironment of tumor, these T cells are not able to detect the cancer cells. So with CAR T cell therapy, we express receptors which is known as CAR receptors on the T cells so that they can identify the antigen on B cells or the malignant one cells, and they can bind them and kill them. They can bind them in and they get the response to that. They proliferate and selectively killing the cancer cells. And since it's an immunotherapy drug and it's a biological thing, it has a lesser chemo-related toxicities, although it has immune-related lots of toxicity that we can discuss later. But these are mostly manageable if done rightly. So CAR T cell therapy is this. It's a game changer. And I believe the future is cell therapy and immune therapy.
Yeah,
Not only for the hematological malignancies, also for the solid malignancies and some benign disorders which are refractory, like SLEs and other.
yeah, I think this therapy is actually reshaping the cancer care, I would say, and it's really interesting to know what exactly this therapy is. Now, speaking of the clinical uses, doctor, what are the current FDA-approved indications for CAR T therapy? And are there any promising off-label uses that are being explored?
Yes. So currently it is used for refractory BALL, relapse refractory BALL with the multiple lines of treatment, and B cell neoplasm, mostly DLBCL, and mantle cell follicular. Off label includes CLL, and like I have told, SLE and all. There are trials going on. Apart from that, there is trials also going for certain solid tumors like lung, gastroesophageal cancers, lots of solid malignancies patients, and it is undergoing. But current FDAs are for BALL, relapse refractory non-Hodgkin's lymphoma, which are B lymphomas, and off-label for CLL.
So now, doctor, could you walk us through the step-by-step process of CAR T cell
Yes,
therapy, like from leukapheresis to infusion and post-treatment monitoring as well? How does the
right.
entire journey unfold for a patient?
So I will give you explain it by an example. Let's
Sure.
assume there is Mr. James.
Mhm.
He is a 60-year male. He is a
Mhm.
case of DLBCL. He has come to me with a progressive disease. So the disease burden was too high. We have to reduce the disease burden before CAR T cell therapy. Then we use a bridging therapy. Okay. So bridging therapy can be
Mm-hmm.
anything, can be a radiation, can be a chemo immunotherapy, or purely immunotherapy, depending on the patient's condition. After bridging therapy, there is a reduction of the tumor. It can be complete remission or partial remission. And in between that, there is a period, at least like for rituximab and some immune related drugs, there is a period 3 to 4 weeks washout period before CAR T cell can be harvested from the body. Or some other drugs like radiation, you need 7 days washout period. For acalabrutinib, you need 48 hours. After this washout period, after one cycle, when you have 1 or 2 cycles per se, when you feel that the response is good, the disease burden has come down, now you decide to take out the T cells in most of the conditions. Sometimes the patient's disease biology is too aggressive, then we cannot wait for bridging therapy also in very rare conditions, although every person should receive bridging therapy, then we can directly harvest the T cells. For harvesting of the T cells, you need a patient should be at least fit without any infection, and his count should be also normal. And we do leukapheresis, that is harvesting of the T cells, which are selective T cells harvest. These T cells are taken by a apheresis machine, that is a few 4 to 5 hours work. And after the collection of, per se, if you say 100 or 200 ml of collection in the bag, we send this bag to the CAR T cell therapy manufacturing unit, which is a GMP manufacturing unit, and
Mm-hmm.
where they use spatial lab tools to segregate the T cells. And these T cells are then genetically modified with the help of viral vectors, and the DNA is inserted, DNA, for changing to bring the CAR expression on these T cells. So that enables the expression of CAR cells on these T cells. Then there is a process of expansion of these T cells. After expansion, there will be a quality check and cryopreservation of these check. So typically in India, we after the quality check, after the viral check, after the total amount of CAR T cells which have been produced, it is not only the CAR T cells. There is a lot of subset like CD4 cells, there are Treg cells, there is different composition of CAR T cells. Among them, there will be a major population of CAR T cell. After we decide that this is the perfect amount of CAR T cells in the product, everything is fine from every point of view. Then we cryopreserve that in minus 80 degree. We keep it, and then after that, we keep it, at least we can keep it for 3 months. Before 3 months, you have to use that CAR T cell therapy. So this is about a CAR T cell harvest. It takes 15 to 19 days for the harvest to product preparation time. After
Okay.
this, once this is ready, then we do lymphodepletion, which is typically with the cyclophosphamide and fludarabine. In some cases, you can also use bendamustine. And then after this lymphodepletion, we need to deplete the lymphocytes in the patients before introducing the CAR T cells. Then these CAR T cell is infused. We must take care not to give hydrocort or any lymphotoxic substances before CAR T cell infusion. And then after CAR T cell infusion, the patient is being monitored. Generally, day 4 or 5, they develop CRS, which is
Okay.
cytokine release syndrome, or
Mm-hmm.
some neurological toxicities can happen, like ICANS, immune cell effector neurotoxicities, and some other fever, or there can be, because the patient has received lymphodepletion, they also gets neutropenic, so they can have a neutropenic infection sepsis along with the CRS happens because the CAR T cells expands and they release lots of cytokines. So there is a because of the cytokine milieu, increase in the cytokine milieu, you get fever and shock, hypotension, and all these conditions, which is graded in grade 1 to 4, depending on the
Mm-hmm.
patient's condition. We generally keep the patient for 10 to 14 days. Most of the patients generally keep on observation for 10 days. And if there is no cytokine, major cytokine release syndrome or no toxicity, the patient is discharged. After this, we do day 28 assessment by a PET scan or bone marrow, both in cases of acute leukemia. There is an extramedullary disease in acute leukemia, and PET scan in DLBCLs or lymphomas. If there is a complete response, then the patient is followed. And along with that, the patient is also, because the patient's B cell has aplasia, so their immunoglobulin levels are also reduced, and we need to see whether the patient is vulnerable for infections. If the immunoglobulin levels are less than 400, and if he's developing infection, then we can give immunoglobulins supplementation, and then we can check subsequently for next 6 to 12 months. If there is no infection, then we can determine based on the clinical acumen and gets treated. Other than that, there are a lot of other like HLH like things, cartopenia, whereas the cytopenia secondary to CAR T cells also happens. So you need to monitor all these things, and lots of infection with CAR T cell therapy, because secondary to B cell aplasia and loss or decrease in the immunoglobulins and decrease in the altered immunity. So all these things are need to be carefully monitored after CAR T cell therapy. That is the most important thing, because in India, there is a lot of side effects, lots of hygiene issues in the patient. So it is not a single time thing. You need a meticulous follow up of the same.
True.
And then, as a routine follow up, they can be monitored.
Yeah, I think post-treatment is really important. Although one more thing that was just coming to my mind is how do you typically manage these complications if they arise? They're like neurotoxicity or CRS or
Yes.
something like that.
So, suppose if a patient has received CAR T cell therapy and on day 4 he has developed some low grade fever, and there is only fever, no hypotension, nothing, only grade 1 CRS. I generally used to follow
Mm-hmm.
those patients. If they have some hypotension and they respond to fluid challenge, then I just continue with the fluid and supportive care. I try to manage them as much as possible with the supportive care. And if the hypotension and there is a fever which is more than 3 days, then I generally try to use tocilizumab, which is interleukin 6 antagonist. And if the patient lands up in grade 3 or more, grade 4, which requires an oxygen support or intubation, then in that case, anakinra, corticosteroids, steroids, pulse, dexa, methylprednisolone, or some refractory cases, you can also try cyclophosphamide in these patients or ruxolitinib. So depending on the patient situation,
Depending. Mm.
yeah, with the Indian CAR T product, with my experience, I was in also in Tata for last means so I have experience for almost 2.5 or 3 years for CAR T cell and managing them. I have realized that Indian CAR T doesn't have major side effects, and there is very less grade 3 or grade 4 side effects.
Okay.
And you can also predict these side effects with some like raised ferritin, the baseline LDS,
Mm.
the condition of the patient, the disease burden
Mm.
of the patient, with the type of tumor, whether there is a CNS extensive involvement is there or not. Then with the ICANS, you can daily monitor his neurological condition. You can ask the patient for writing. The first thing that I notice is they generally don't are not able to type on mobile. This is the first
Oh,
sign which I feel that they have some neurological toxicities with the CAR T cell therapy. These are the practical things that you see on seeing these patients daily. And other than that, most of the neurological toxicities can be managed with the steroid or anakinra, and that's it. Or with some refractory cases, I have told already.
yeah, it's
Later
really
part,
reassuring.
yeah.
Mm-hmm.
So later part, even after CAR T cell therapy, they can have a delayed. So if the patient has raised ferritin upfront or LDH or the hematotox score is high, then it shows that the patient can develop these kinds of conditions. So, with the help of some supportive management along with GCSF or blood stimulating agents you can give, or some blood products if they have some cytokines, then you need to give them some prophylaxis like cycloviriseptran drugs for viral and bacterial prophylaxis. So these are the things that we need to take care. Basic important thing is you need to do a lot of monitoring in these patients,
Right.
and if you are able to manage them in a day-to-day basis, that is good. They don't generally complicate. If they only
Mm.
become complicated if we
It's
and the
early
patient is
detection.
careless, or if a
Mm-hmm.
doctor is not able to tell them properly what needs to be done or not. And for infections, immunoglobulin supplementation timely is very helpful. First fever or anything, they need to consult the doctors. Most of
Mm-hmm.
the time, it's very comfortable. With my all patients, they are doing very well. Hardly lymphoma patients required immunoglobulin. In fact, they have resumed their work also. They are doing
Oh,
their work
that's so
from home.
reassuring.
Yes, and some of my overseas patients are also doing good. They are enjoying their life, their second life. So it feels good. Yes, it
Correct.
feels really good. Because previously they were advised palliative care in their respective
Oh,
countries, because and they have lots of financial issues. In India, we can solve these problems because the Indian CAR T is relatively cheap, and if you use it smartly, then there is a good chance that they can get a remission.
correct. That's really reassuring to know, and also how it is helping the entire quality of life also of the patient is really
Definitely.
interesting. So
Yes.
now, Doctor, looking ahead, where do you see CAR T cell therapy evolving in the next 5 to 10 years?
So I believe there is a lot of scope in next 5 to 10 years. I believe the most of the things will be shifting towards immunotherapy,
Mm.
cellular therapies, not for only hematological malignancies, in some solid malignancies as well. Currently, there is lots of challenges in the solid malignancies because of the microenvironment problems, because of the lesser accessibilities of these CAR T cells. The CAR T cells are not able to enter into the tumor milieu, and there is a lot of problems with the solid malignancy. But I feel with the kind of research going on and day-to-day improvement in the CAR T cell, and everybody is so excited about it, then definitely I feel there is a bigger role. The current cost also will come down to a larger bit. And I feel there will be mostly the CAR T cell therapies, mostly the cellular therapies, also bispecific therapies will be there. We will be seeing changes in the treatment of myeloma also, in the lymphomas, in the acute leukemias. So currently these are for relapse refractory cases. We will see gradually they will be coming for first or second line options also. And it is very promising. Only thing is, we need to be very careful in using them. And there are certain conditions where is autologous transplant is better than CAR T cell therapies. There, we should be very judicious not to go for the hype of CAR T. We should use whatever the right thing which is suitable for the patient. We have to take care of the cost of the patient, finances of the patients. We have to take care of the disease biology. If the disease biology is bad, then we have to tell the patients that probably your conventional lines of chemotherapies will not work, or if at all it works, it will be for a shorter remission. So we have to tell them, and we have to arrange the finances also. Current in for
Yeah.
Indian scenario and for outside also. And what I have noticed is most of the patients, when they are in a terminal stage, when the disease is progressive, then the physicians or clinicians tell about these options. Instead,
Oh,
these things come up earlier. At least the
earlier.
patient's
Hmm.
party needs to be prepared at least 4 to 5 months before, so that they can arrange the finances. Because it is very
Right.
difficult to arrange 40 lakh, 50 lakh rupees in 10 days span. Nobody can do this until
Nobody.
unless you are a
True.
filthy rich people. So we have to be very smart in this. We need more educations, and the
Hmm.
doctor should be aware of how to use it smartly. These are all the things that these are the challenges that I feel in next 4 or 5 years with a better education it will overcome all these hurdles. So more and more doctors will be going for that, and more doctors will be knowing how to use
Again.
it and
Yes.
how to manage that. There will be a time when CAR T cell will be used on a OPD basis or a daycare basis also.
Oh.
But right now it is done in US because they have a very clean system, clean environment, hygiene, educated patients. In some patients in India you can try where there is a low risk of toxicities, CRS and ICANS. But for the majority of patients you need some observation because these are the things
Yeah,
that
I understand. I think that's such an exciting future to look forward to
yes,
also. So now,
definitely.
Doctor, the final question is something that is very important for our listeners and my personal favorite also, that for oncologists and hematologists who are considering integrating CAR T therapy into their treatment protocols, what key advice would you give them?
So, my first key advice is to identify the CAR T eligible patient early. Identify the disease biology and aggressiveness early and act accordingly. To integrate and make a good team, including neurologists, including infections disease support consultants, or better ICU support at their native places. And you need to learn how to use CAR T in a effective way because we cannot expect a CAR T cell to work on a 15, 16 centimeter tumor alone. There is a CAR T cell exhaustion. You need a good bridging therapy for that. If you are not able to bridge them adequately, then unfortunately, the remission, if at all it achieves, it will be a shorter remission. Then we have to be very wise in selecting patients. Yesterday, I have came across a patient when the patient was HIV positive. So there was T cell dysfunctions because of HIV, as HIV virus is integrated into that. So there was a product manufacturing defect because the patient was HIV positive. So the CAR T cell cannot be produced in this. These T cells are not able to do work. So unfortunately, if you use this product, the CAR T cell will not work. So we have to be very vigilant, and we have to first formulate what is the right selection of the patient. The selection of the patient is very important. Timely selection and timely guidance of the patient is very important. Then adequate bridging is very important, and planning of CAR T cell infusion along with a good team, preparation of a good team, and collaboration with a good ICU support is very important, and timely monitoring of the patient. It is not the single time procedure, it is
Alone.
a long follow up and a
Hmm.
meticulous follow up, and we have to be very careful of the infections in Indian scenario. That is the most important thing. I have seen lots of patients post CAR T who have succumbed to tuberculosis or something else. So lots of infections, not only because of the disease they succumbed. So these are the things that I want to tell them.
Yeah, I think
And it's a learning curve. Everybody is learning. With the
hmm.
more and more cases, everybody will learn. Everybody should share their data and their experience in their forums or the publications so that other people can learn from their experiences.
True. I think timely execution, planning, and intervention is really important.
Yeah,
So, thank you for sharing that. And Dr. Goel, this has been an eye-opening discussion. And CAR-T therapy is not just a treatment. I think it's a game changer in the fight against cancer. So, thank you so
definitely.
much for your insights and incredible valuables that you've shared with us today. Thank you so much.
Thank you. Thank you so much, Hedvi and MedSynapse community.
Thank you. And to our listeners, thank you for tuning into this episode. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and keep learning.